Rahim. I'd like to welcome you again in the fourth and the last day of our US course. Today we'll have very nice lectures and very interesting lectures. And I have the pleasure and honor to share my colleagues from Egypt and Poland this day. Dr. Anna Kozłowska from Poland, Dr. Katarzyna Pawlak from Poland, Dr. Rasha from Cairo University, Asyut. I'd like to thank Utopia Pharmaceutical Company for their great effort. And I have pleased and honored to invite my dear colleagues as commentators. They will comment on the lectures. Dr. Professor Mohammed Naguib, my best friend and brother from Cairo University, Dr. Wael Abbas from Asyut University. Now it is 7:30 exactly, and we will start our first lecture by Dr. Anna Kozłowska from Poland. Most welcome, Dr. Anna. She will talk about US celiac plexus block and neurolysis. Anyone to ask any question, he can go to the bottom of the screen to the Q&A icon and write his question or her question. And at the end, we will ask all the question transmitted to us. Thank you very much for your interest in endoscopic ultrasound. And now we'll start by the first lecture. Dr. Anna, please.
Hello, good evening. Thank you very much. It's a great honor for me and a pleasure to take a part in your conference. Thank you, Professor, for invitation. It's a very important thing for me and the possibility to meet with you straight from Poland. The title of my lecture is US-guided celiac plexus neurolysis in the management of pain secondary to unresectable cancer pain. As unfortunately, the pancreatic cancer has the worst prognosis among all solid tumors and the carcinomas. The prognosis is this carcinoma is very poor, and more than the half of the patients do not survive beyond 1 year. So one of the most important kind of treatment in this kind of disease is rather palliative treatment with the treatment of pain. Up to 80% of people are suffering of abdominal severe pain, and it's a big problem for this kind of patient. These pictures are typical in our practice when we are talking about pancreatic cancer. Unfortunately, the higher percent of performing in this kind of disease, US procedures are showing advanced tumor with hypoechogenicity, with irregular surrounding tissue, with inflammation for the vessels and different organs around, with suggestion for metastasis, dilatation of the bile duct and pancreatic duct, sometimes after thrombosis in the vessels. So the goal of treatment is definitely palliative care and not curative in the majority of the patient. So pain control is the major goal when we are talking about palliative care in advanced gastric cancer. Celiac plexus neurolysis is one of the possibility of the treatment, and this kind of procedures first time was described almost 100 years ago by Capis. So for about 1 century we are talking, and we are able to perform this kind of procedure with different approaches as percutaneous, surgical, and sonographic, which first time was performed by Wiechowska in 1996. The different benefits and possibilities of this method I will try to explain and focus during my lecture. Different approaches and different substances are were performing during neurolysis, and we should decide when we are talking about neurolysis and about plexus block, because when we are talking about celiac plexus block, we are thinking about temporary block with rather steroids instead of alcohol, rather in the treatment of chronic pancreatitis. When we are talking about neurolysis, we are talking about more permanent therapy using alcohol in the adenocarcinoma. The beginning of therapeutic US procedures is the beginning of 1990 years. And nowadays, as we know, we perform a lot of different complicated procedures, and collection drainage was one of the first, and celiac block and neurolysis were these first on the beginning of therapeutic possibilities. And we are having different drainage, different therapy, but all over the time, US guided neurolysis is performing in many centers in the treatment of the pancreatic cancer. In 2017, American National Comprehensive Cancer Guidelines has applied this kind of procedure as a minimum invasive approach in the treating pancreatic cancer, and this kind of method is recommended for treatment of severe cancer associated pain. So it is so important message that for so many years, this kind of procedures is all over the time important in this kind of treatment. Who should we treat and qualify for this kind of treatment? Definitely the patient with advanced pancreatic cancer with unresectable stage who experience pain affecting their quality of the life. This group of people are good candidates for the treatment. Definitely, these who are not a good candidates for surgery are the main group of people who should be qualified for the treatment. Contraindication, coagulopathy, patient with cardiorespiratory instability, advanced gastric varices, and different anatomical abnormalities after surgical treatment, after with very big tumor with invasive into this area, and lymphadenopathy sometimes could be also this abnormality, which gives us different difficulties to perform this procedure. What equipment we should have for the performing the neurolysis? Definitely therapeutic US with the needle. It could be standard 22 gauge needle, but also in a lot of papers and in my center, we use this needle dedicated for this kind of procedures is 20 gauge needle with a spray. So multiply side holes on the top of the needle, which facilitates so spreading of the material is much better on the bigger space in the shorter time. And it's much easier to put a bigger volume of alcohol into the area. So this needle by Cook Company and ethanol, 96% ethanol with lidocaine are necessary for performing this procedure. Many centers are performing neurolysis. Procedures can be performed for outpatients, it's important. The sedation is required. Dehydration before procedures should be also recommended before the endoscopic procedures to minimize risk of hypotension. Non-invasive monitoring of blood pressure and pulse, definitely. Aspiration tests during procedures. We should start the procedure for aspiration test to be sure that we are not inside the lumen of the vessel. And later, as the first bupivacaine, lidocaine injection, followed by alcohol. Monitoring of the vital signs for the time of 2 hours. should be enough. And if the person after a few hours after procedures is without any complications and any problem, so we should treat them as outpatient. The picture of US, this schema showing us how short way, how close we have celiac plexus through the from the top of the echoendoscope. So how close is this area, and how good and precise lumen are we able to obtain during this procedure. So during performing celiac neurolysis, we should visualize aorta with a typical angle of celiac artery. So this artery, this area between anterior wall of artery and celiac trunk, the next vessel here is superior mesenteric artery, and this area, sometimes with the possibility of visualization the ganglia, is important for performing US celiac plexus neurolysis. We have two different possibilities of performing this procedure. One of them is known central injection, when we have to input advance the needle in the center of the angle between the aorta and celiac trunk. And this short picture, which I would like to show you, with the injection by the needle in the central part of this angle, with this typical cloud over the aorta. So it's one of the technique performing during this procedure. If we have a good area and enough place for performing this kind of procedure. And the second technique, known bilateral technique, when we rotate the top of the echoendoscope to the right and to the left, and this moment the vessels disappearing from the picture, and we input a part of the, for example, a part 5 millimeters of alcohol into the right side and into the left around the celiac trunk. In both of these techniques, this white cloud is over the aorta and celiac artery. And this is what I mentioned before, that we are able to find also the celiac ganglion during the procedure. And the authors of many papers are trying to underline that this is much more effective, and it is possible to recognize this ganglia in above 60% of the patients. So it could be the better predictor when it comes to the response for the treatment. When we are talking about accuracy, it's very different, between 50 and 90% in different approaches, in different papers, in different studies. What we should be focused, and what we are talking about, thinking about efficacy of celiac plexus neurolysis. Definitely pain scores using a standardized 11 points continuous scale, with 0 equaling without pain, 5 moderate pain, and 10 with severe pain. It's rather the main option for recognize efficacy in majority of the papers. Sometimes also they mention about decreased in opioid consumption. The efficacy for pancreatic cancer is very different. During about 20 years of using this kind of method, we have different studies and with different results. The first very good study, 2008, with non-resectable pancreatic cancer with very good results, above 90% of efficacy in the treatment. The second meta-analysis, about 80% from the 2009, Barpuli, in about 300 patients, the biggest group of the patient of the study, with efficacy in the reduction of pain in 80% of the patient. And meta-analysis with 5 studies by Kaufman, lower efficacy about 70. So I would like to underline that we are not talking about pain removal, but only about pain reduction when we are talking about celiac plexus neurolysing. The complications in the papers and in my own opinion, performing this procedure for many years, it's rather safe technique. Transient hypotension immediately after self-limiting diarrhea, severe pain during or after procedure, which rather should be treated as not a complication, but rather a symptom of the procedure. So rather very light complications and very rare, between 3 and 33% in the papers. Last study on the biggest group, 661 patients, about 20% of complications, but I would like to say that always very light symptoms, not serious, with not any important treatment. When we are talking about serious complications, there are very rare and occur rather in the simple cases in minority, only 0.2% when we are talking about serious complications. In the literature, we are talking about 1 patient with retroperitoneal bleeding, 1 patient with complete thrombosis of the celiac artery, also infarction of hepatic and splenic artery, paralysis due to anterior spinal, very serious complication, but also only 1 in the literature, in the papers. Also very rare infectious complications, including retroperitoneal abscess and empyema. So in my center, in our center in Poland, in Szczecin, it was the first procedure in Poland performed in our center in 2008. And we performed this study with the patient, 29 patients treated this kind of method. We observed early and late results, efficacy of this treatment, and it was above 70%. We performed different approach towards the plexus, central or bilateral, depends on the anatomy and the better position and the better possibility of achievement this plexus. In our paper, we didn't observe any serious complications, only this kind as hypotonia and exacerbation of pain and the diarrhea. So without any serious complication, it's very important, and I would like to say that majority of patient is free of any consequences when it comes to the different problems and symptoms. The main problems what we should ask talking and the problems and the points to the discussion is the learning curve, certainly as in each procedure, different approaches toward this place, different concomitant therapy, the timing when we should start to perform this procedure, what kind of dose, maybe increasing of the dose of the alcohol should be definitely enlarged, and is the possibility of repeating this procedure for better efficacy of the treatment. When we are talking about approaches, that there are different opinions and different papers. Looking at the first very important paper by Sahai from Canada, Montreal, in 2009, he recognized that central injection had much more poor prognosis when we compare this with bilateral treatment, which was above 85%. But the next papers from different centers, didn't agree with this opinion because they didn't find any difference between central and bilateral treatment in a big group with randomized trials. The chance maybe and the hope for the better efficacy could be celiac ganglion neurolysis when we input the alcohol precisely into the ganglia, and the author in 2013 Doi recognized that above 73% of people had the result and better efficacy when he compared this with typical neurolysis. Also, the result when we are talking about concomitant therapy, that when we perform this in the group of people during chemotherapy, that the results of the treatment are probably better and the relief of pain is better. The timing, when we should perform on the beginning of disease, when we recognize adenocarcinoma, or in very, very advanced disease. Definitely more effective treatment we are able to achieve when we perform early after pain onset. For example, the efficacy of AWS in early pancreatic cancer pain was achieved even above 90%. When we compare this in the terminal stages, about 50%. So these differences are huge, and maybe it's also the reason why the efficacy is so low, because maybe we perform this kind of procedure too late, and in unresectable tumor and pain requiring narcotics when the patient are too advanced in the treatment. We shouldn't perform this kind of treatment only in the patient with failed medical management. Aerial therapy may be better than waiting for the medical failure. So maybe it could be the answer for better answer. High quality prospective randomized study definitely are required to efficacy this pain relief in malignancy, in adenocarcinoma, but also in the chronic pancreatitis. The most optimal technique should be decided, and the best timing to undertake this kind of treatment. Some hopes are with new techniques when we are talking about guided broad plexus neurolysis, when we extend over the superior mesenteric artery using 25 gauge needle, the work from last years, and a new possibility of performing this with radiofrequency instead of alcohol from last year, a new paper that maybe it will be a chance that instead of alcohol we could use radiofrequency as is for the neuroendocrine tumors or cystic lesion in the pancreas. Thank you very much for attention, and it was a pleasure for me to meet you in these so difficult times, but straight from Poland and to come to Egypt. Thank you very much.
Thank you, Dr. Anna, for very nice and detailed lecture. I think most of the audience understand it very well, and we didn't have a lot of questions. Maybe only a question about what is the recommended amount of lidocaine and alcohol injected. Hello?
What do you mean about alcohol?
The dose, how many cc's,
how many? About, yeah, rather about 10 milliliters of alcohol, but they are purpose with using about 20. So from 10 to 20 milliliters, yes?
Yes.
In one injection or bilateral.
How much lidocaine on it?
Maybe
Only
also
2
5 to 10.
Only 2 milliliters as the beginning, yes. But there are papers also that if you use this with sedation, in some centers they don't use lidocaine, yes, only alcohol, because the patient doesn't feel a pain. But because the pain could be longer for the procedure, so I recommend, and in many papers we recommend 2 milliliters of lidocaine and later 10 milliliters liters of alcohol.
And do you recommend mixing the lidocaine on alcohol or?
No, rather on the beginning, because I perform this in the sedation only with midazolam and yes, so in this situation we are in touch with the patient, so we perform lidocaine and later alcohol. But in the other option is to mix this together, so it's not so important.
There is no difference between mixing them or injecting the lidocaine in the beginning, then flushing the needle, or followed by the alcohol after that on the same needle without changing the position or changing anything.
Yes.
But
I would
if you
like
mix,
to also
I think it will be different. If we mix lidocaine with the alcohol, it will be the different concentration of alcohol. Lidocaine may be containing water, so it is not absolute alcohol.
Yeah, but the difference in the results, there are papers with different possibilities, yes, but rather we recommend in majority of papers as a phase lidocaine and later to 96% alcohol, yes, but it's also possible to mix in some papers, yes. I would like to underlay that I didn't tell, maybe I missed this, that sometimes during one procedure we are able to perform diagnostic procedure of US with biopsy when we have the patient with typical picture of US with typical clinical symptoms with advanced and very severe pain. So during the same procedures we are able to perform biopsy of US to confirm diagnosis and perform neurolysis.
It will be better for pain control, I think. It will be better and longer duration of response. Dr. Hussein, we have time for
yes,
another
we
question.
still have
Question.
4 minutes, and I'd like to ask Dr. Anna two short questions. The first one, sometimes the tumor, especially in the pancreatic body, is very large and invading this area or this angle between the abdominal aorta and the uptake of the celiac axis. So if you inject in this area, it will be injected in the tumor tissue and not in this area. Would you abort the maneuver if you find this situation, or what we will do?
Yeah, as I told before, sometimes we are not able to perform, and it's one of the contraindication when we are not able to find a good area to input the volume of alcohol, yes? So sometimes we have to give up, and in our study we had to give up in 2 patients that we weren't able to perform celiac neurolysis of this reason. But in other situations, sometimes we could change the position. For example, instead of the one puncture, the central puncture, this bilateral, if we have, for example, lymph nodes on the part of the tumor, yeah.
Yes, the
but
second
not
question.
always it's possible.
Okay, thank you. The second question regarding mesenteric plexus neurolysis. Sometimes in my patients, the celiac plexus neurolysis don't work well. The pains is not relieved. It's not effective in about 40% of our patients. We did with, especially with Dr. Wael Abbas, many cases, more than 150. And in this cases of failed celiac plexus neurolysis, in the second time I try to do mesenteric plexus neurolysis. What is the recommended plan? Inject how many cc's in the celiac again, or inject the whole amount in the mesenteric? In mesenteric, we are deepening the needle about 1 to 1.5 centimeter below the celiac axis to reach the uptake of the superior mesenteric artery. Then would you distribute the amount of alcohol bupivacaine between the celiac axis and superior mesenteric, or inject the whole amount in the superior mesenteric because injection at the celiac failed before? What is your plan by then?
Yeah, it's a difficult question. Yeah, it depends because as you know, the localization of the tumor depends of is it in the end of the pancreas, is it the corpus? So I think that the reasons of the pain are different. So also the results of our treatment are different. In my opinion, definitely the bigger volume of the alcohol. So in my study, I performed rather 20 milliliters instead of 10 milliliters, which is recommended in the majority of the papers, yes. The second, if I don't have effect of the treatment, I use, as you mentioned before, different position, and with different, that sometimes I put this, if, for example, during the first procedure, I had only a central by spray needle. So the next time I perform this different technique with bilateral, yes. So the changing the position and the changing the volume, definitely the bigger volume. But if 2 times I don't have any effect, I send the patient for a thoracoscopy and splanchnicectomy in this situation. Because not always, I told that not always and not often we receive the completely relief of the pain in the patient. Unfortunately, sometimes we are disappointed when it comes to this kind of treatment in advanced. So this was the reason why I gave so many inquiry. What way should we improve the quality and the efficacy of this kind of treatment?
Last